Starting us off in a good way, we want to acknowledge and respect the Lekwungen, Songhees, Cosepsum, Esquimalt peoples on whose territory the university stands, and the Lekwungen and Wasanich peoples whose historical relationships with the land continue to this day. We love to live and play in Victoria and are so grateful for its natural beauty and the stewards of these lands. Today, we are thrilled to have Dr. Katherine Kim with us. Katherine Kim is a consumer health informaticist with expertise in digital health, AI, and community engaged innovation. She's an adjunct full professor at the University of California, Davis School of Medicine, Department of Public Health Sciences, and senior scientist for Citrus Health at UC Berkeley. In addition, Dr. Kim is the founder and CEO of Health Equity LLC, a digital twin and care coordination platform. Health Equity has won awards for its co-design approach, real-world health outcomes, and innovative AI digital twins. Dr. Kim is an internationally recognized researcher and elected fellow of both the International Academy of Health Sciences, Informatics, and American Medical Informatics Association. Dr. Kim serves on the board of Archstone Foundation, a grant-making philanthropy dedicated to the health and well-being of older adults in California, as chair-elect of the board and chair of the program review committee. She received her PhD from UC Davis, MPH and MBA from UC Berkeley, and BA from Harvard. So just a quick reminder or maybe news to those of you who are new to our webinar format, but please, we invite you to ask questions at any point in time during the presentation today, but contextualize them if it's about a certain framework or slide, because Dr. Kim is going to wait till the end and then we'll have a Q&A session back and forth. So you're welcome to ask a question as it pops up or hold on to it till the end, whatever works for you. But without further ado, thank you so much for joining us, Dr. Kim, and telling us more about digital health equity frameworks, state of the science, and opportunities for advancing the field.
Thank you so much. I am so pleased to be here to share with you my work. And I'm going to just bring up my slides here. All right. So I'm really pleased to be here. Thank you so much for this invitation. And I'm looking forward to the conversation that we all have together. So I want to start out by framing what I mean by digital health. Often people define digital health in terms of a set of technologies. I think of digital health really as an ecosystem, right? The ecosystem is health first, in which we are using technologies to support the use cases and the interactions and the services that we provide for health. So those use cases are really above the first level at the top of the screen. Those use cases where we use technology might be for the goals that we have for our health, whether they're our individual goals or clinical goals. They might be specific services like remote monitoring for chronic conditions or things that we do in the hospital, telemedicine, surgical robotics, and many other things. The technologies, of course, are important. So there are a whole continuum of sets of technologies. People often think of digital health as just those technologies that consumers use. So that's kind of what's in the first box on the lowest level. These might be remote monitoring devices or wearables or mobile applications that people are using. But there are also technologies that are used by the healthcare providers as they engage with patients. So it's a whole set of different kinds of technologies. But in that technology ecosystem, I would include many other things that maybe patients don't use directly. Things like augmented reality and other visualization systems, the actual data and making that data interoperable and computable, the computational and analytic techniques themselves, how we generate insights and who those insights are made available to. Artificial intelligence, of course, now becoming ubiquitous in everything we do. And then finally, the policy and governance infrastructure. So relevant to our talk today, there are barriers at every one of these use cases and every one example of these technologies. And they are barriers to the equitable use of the technology itself, barriers to accessibility of the services related to those technologies, barriers to care in which you are able to use technology in those services, and then barriers to health itself. So this is the digital health ecosystem that I'm talking about. As we go into talking about what are the frameworks for interventions in this ecosystem, we really do have to understand the ecosystem itself. The second concept that I want to raise here um, are, are, are those related to health equity and health justice. So you have probably seen some version of this. This is a very common sort of visual of this, where you think about inequality as the unequal access to particular opportunities. And if you're just trying to do equality, you give everyone the same chance to do the same activity, right? You give them the same level of the ladder. But equity is when you take into account the context in which each individual is trying to have equal or equality in terms of healthcare. And some people have less resources, have less opportunity, and so they need a taller ladder than those who have more resources. So equity would be giving them the equal opportunity by giving them resources that they need. And the final is justice, right? Justice is, of course, providing equality and equity, but taking it to the level of the context and changing the system in which we provide equity and equality. So I wanted to raise those concepts because that's really important, I think, to these frameworks. So there is a digital divide globally. This is a graphic that shows the level of connectivity for populations across the globe. These are the numbers are the number of people in these areas that don't have internet access, and you can see it really ranges very broadly from the highest level of the highest number of unconnected people being in Eastern and Western Africa, as well as Southern Asia. And then a whole range of different things. The lowest level of being disconnected is in Northern Europe, but it really varies dramatically across the globe. And there's another aspect to this, which is the difference in connectivity for urban and rural populations. So within each of those global regions, there is a disparity between level of connectivity for the urban population versus the rural. And in every case, urban populations have greater internet access. So I'll talk a little bit about the US. I'm here from California, so I'm going to talk about what's happening in the US. This is a broadband map that's provided by the Federal Communications Commission. And if you were to look at this infographic, and you would say, well, my goodness, we have pretty much everybody connected. 99.7% of locations in the United States, at the bottom left of this infographic, has very high level of connectivity, right? On the right, it's 96.4% have 5G. 95% of homes and businesses have this sort of 100 by 20, which is the definition of the bandwidth that you need for internet. So it just seems like, boy, everybody in the US must have connectivity. But this really is an underestimate because the data comes from telecom companies. What they're really telling you is what areas have access to this level of connectivity, not really how many people actually have it. So if you have a county and you have one access point with this level of bandwidth, they say everyone in that county has the access. So that's why it seems so high. So there are definitely there's a digital divide, and you can see at the adoption rate compared to the national average. Low income, older adults, rural households, these groups still lack the access. And again, this is still based on the FCC data, so this is an underestimate really of what people have available. But even given that, we have the majority of people in the United States, and this is all adults, that are using some form of digital health. So 58% use some kind of virtual care in the past year, and we know that really increased dramatically during COVID-19. And some of that has reduced a little bit, but people, are still using it in substantial numbers. 53% own at least one wearable or connected device, and 54% track at least one health metric digitally. So the majority of people are using digital health. So what are the differences in terms of wearable usage? So here again, age and income will influence ownership. So most of these kinds of devices, which would be your, smart watches, your rings, those kinds of things that you are wearing, and primarily fitness devices, they're used by younger people and they're used by people who have the disposable income to purchase them, since these are not things covered by any kind of healthcare insurance. There is still an urban and rural divide. Surprisingly, Black and Latino consumers are actually wearing wearables at higher rates than other populations. We saw the same thing with smartphone usage. When smartphones first came out, Black and Latino users were faster adopters of smartphones. Insurance and health status matters. So people who have private or employer provided health plans are having these kinds of wearable devices at higher rates than others. And we still have issues with adoption in certain communities, such as older adults, rural, and lower income. So let's look at one of the newest technologies to hit the public, which is AI chatbots. We know that ChatGPT, the first version of ChatGPT came out in 2023. So we're only talking about 3 years of history, less than 3 years of history here. But AI chatbots have really grown dramatically just in this 2.5 years. But it differs by generation. So the younger generations are definitely using chatbots at much higher rates than as you go to the older generations. Similarly, with wearables, you're seeing that there's a greater adoption of AI chatbots among minority groups compared to white respondents, and about equal for men and women. So, what are people using chatbots for? Well, they're using it for everything. You can see people, this is a survey that was done where people could pick multiple options, so it's not mutually exclusive. But you can see, majority of people using it for searching for information about a potential diagnosis based on their symptoms, about treatment options, about drugs and side effects, and about wellness and prevention information. They're also looking for information about the actual process of using healthcare coverage. So, what kind of questions should I be asking before an appointment? That's at the bottom. Or how can I find a specific provider for what I need? Or understanding insurance coverage. So, people are using chatbots for pretty much every aspect of health and wellness, and this is pretty dramatic given that they're only a couple years old. So in terms of digital divide, this survey also looked at AI users versus non-AI users. And not surprisingly, those who are using AI are also using all these other kinds of services that are related to digital health at higher rates than those who don't use AI. So tracking health metrics, using virtual care, owning a wearable device, using at-home test kits, or owning a connected medical device. In every case, the AI users are adopting these at higher rates than non-AI. So you can see that we have not, even though we see Black and Latino users using AI chatbots more than white, for example, we still see this differential. The people who have access to wearable technologies also have access to AI. And the vice versa is also true. So we don't know then, we cannot assume that AI is somehow shrinking that digital divide, right? Some people might assume that, but we really don't have evidence that that's what AI is doing. Okay. So I'm going to move on to digital health equity frameworks. And this is work that was just recently published. It was based on a scoping review that we did. So let me tell you a little bit about the rationale for doing this project. So before we started, we kind of challenged ourselves to say, what is the logic model? Why would we care about digital health frameworks? So we said, if digital health is an ecosystem, and we believe that it is, and the characteristics of the ecosystem includes people, technology, process, structure, and context. And inequities are impacted by both the intended and the unintended characteristics of the ecosystem. then in order for us to develop digital health interventions or programs, we have to attend to that ecosystem. So then the question was, how do we design an effective digital health equity intervention or program? And that's what drove our systematic review. So one of the first questions we asked is, what is digital health equity? We don't have a definition for this, right? And are there frameworks already that can guide us in the development and evaluation of these interventions? So that drove our research project, which was a scoping review of the literature up to December 2023. And you can see the Prisma diagram to the right, but it was conducted in adherence to the Prisma scoping review protocol. We started with 910 papers. We did screening, we did full text evaluation, and we had independent review and then consensus or discussion and mediation. And we ended with 44 papers. We actually did this scoping review across multiple databases. And you can see that our frameworks that we identified came from many different fields: biomedical, population health, computer sciences, or information sciences, and computer sciences. And among those 44 papers, they actually referenced 42 frameworks. So 22 were existing and 20 were newly proposed as part of those papers. But out of those 42 frameworks, 13 had a major emphasis on digital health equity. And among those 13, only 8 actually had concept definitions. So this was even at this phase of where we were just screening these papers, we were already seeing that even though we're finding a lot of papers and we're finding a lot of frameworks, they are not very mature, particularly if they're not even defining concepts yet, right? So we had a lot of work to do. So here are some of the results. So first, that question about what is digital health equity? So we looked at the papers that did have definitions of this as a concept. So they might not have called it digital health equity, but they were trying to define this concept. There were actually 5 papers that actually even attempted to define digital health equity. So we put those together, and we did a concept analysis. So we looked at all the words in all the definitions, and we came up with themes of what they were trying to represent. And you can see that in the graphic to the right, that the themes that these papers represented in their definitions included something around equity. And these are some of the words that we found: something around equity: fair, just, everyone. That was some state that was before action occurred. So words like opportunity, access, readiness. And then there was an action. An action, the action words included things like use, experience, develop, design, and then access as the verb, to access. The fourth concept was solution. Some sort of representation of solutions. So maybe it was digital, it was tool, services, resources, or practice. And the final was some result being health, outcome, benefit, or impact. So when we did that analysis, we realized that we had actually come up with a consensus definition. There was a lot of similarity in what they were trying to represent, maybe with slightly different words. But we put that into a consensus definition, which is digital health equity is a multi-level socio-ecological concept that results from fair and just opportunities for everyone to attain their highest level of health through access to technology-enabled health resources and services. And then we propose this for digital health equity interventions. They apply technology-enabled solutions to deliver health equity impacts. So that was our first result. We did our analysis using Bronfenbrenner's seminal model, socio-ecological model, which has 5 levels of interaction, right? The individual or family, interpersonal, local, community, social norms or society, and then time. We actually did not use the time element of this, but we used the others. And that was to analyze the frameworks and the concepts in the frameworks. So now these are the 42 frameworks that we're analyzing, not individual papers, but the 42 frameworks. And so among those frameworks, we looked at the five levels of the Bronfenbrenner sociological model. And we identified the five levels as individual, interpersonal, organizational, community, and societal. So we use those five because a lot of papers in more recent papers in public health and healthcare services were using these five levels instead of including time. So we didn't invent these five levels. They are actually referenced in a number of papers that use this model. And you can see we mapped every framework to these five levels and said, does the framework actually address this particular level? And you can see that almost all of them, or not almost all of them, but a large majority of them, 27 represented organizational or program level concepts in that framework. Individual was represented in 17, and the community was represented in 13. But very few really addressed interpersonal and societal. So there's a real gap in the comprehensiveness of the frameworks for digital health equity in the levels that they pay attention to. And it's particularly important, we think, that societal level being what we're trying to accomplish in the world, right? Are we trying to improve population health? Are we trying to improve public health or access to healthcare services as a broad societal goal, for example? Most frameworks are not addressing that. And then the interpersonal, the relationships between actors. Most of the frameworks are not addressing those interactions. It's as if you stay within your level. And what's important is the interaction only within your level. When we know that how we interact with other people in society and the environment and the context and the organizations, all of those interpersonal relationships and interlevel relationships are really important. So we felt that there's a real gap in frameworks because they have not comprehensively addressed all of these levels of interaction. So we also extracted all the concepts that were identified across these frameworks. We found 243 individual concepts among the frameworks, and we grouped them into themes. Things were as not necessarily themes, but in terms of concepts that were closely linked. So we grouped them into 43 categories, and you can see the categories here. I think this is an area of opportunity that I will touch on later on. But many of these concepts, as you saw, many of the concepts are not defined. And so a lot of frameworks may say them, but we don't actually know what those authors meant by those concepts. And nobody so far has taken this concept analysis across the frameworks and really carefully analyzed, are we talking about the same thing? Or are we just using buzzwords? And that I think is it's problematic for scientists if we're relying on buzzwords to actually make scientific findings. So I think this is an important area for us to work on. So we did the first step, which is we just categorized them. So what are most like each other? And we came up with these 43 categories. But you can see some of these are really important conceptual categories. Um, Access to digital health services. What do we mean by that? Even though we have some examples, we don't know what people include in that. Implicit bias, either implicit, that's number 23 and 24, for example, implicit algorithmic bias, implicit technology bias, digital literacy, which is number 26, perceived value. If people are going to use these technologies and these interventions, or organizations or communities are going to invest in them, what is the perceived value? And is that even an important thing to consider before you start rolling an intervention out? So we just found these very interesting. I think there's a lot of work that could be done here. Okay. So I'm going to talk about a few opportunities. One I think the next opportunities is for us to move toward a proposed framework that would allow us to really think in a structured way and in a comprehensive way about how we create interventions for digital health equity. This is kind of a first version for us where we took all that we learned, and there's another previous study that we did, which was um, a key informant interview study. And actually, we have just completed a national survey of community health centers on this same topic, which I will be presenting at the American Medical Informatics Association next week. So this proposed framework is actually taking all three papers together. And what we're trying to represent here, and I will say this is just our conceptualization of this. We have not tested it. We've not, gotten expert feedback. We've not done anything else. So this is just take this with a grain of salt that this is our thinking about how a framework might get composed. So in this proposed framework, we start with the concept of the sociological model. And we say there is a larger environment here. There's a societal environment, which includes market characteristics, the policy environment, the physical settings or physical characteristics of locations, population characteristics, that we need to be thinking about the context and not just the program or the players. That we start with some sort of societal value, and that at the top is the digital health equity outcome. What is the outcome that we are trying to accomplish here that has value to the society, not just to the specific users or the specific program, the sample if it's your if it is your research study. And then you think about all the factors that might affect a program, the supply, what is the availability of technologies, the availability of broadband and other aspects that you need to develop an offering. What's the demand? What do people care about? What do your organizations and your individual members of the community actually care about? What do they want from potential solutions? What are their needs? So you need to know if there's any kind of demand from the population. The third in the sort of in the middle and the bottom are partnership factors. So because many of these interventions are complex interventions, they're not one component interventions. They're complex interventions that might include technology and training and digital inclusion and outreach and healthcare services and different ways of communicating. These are complex interventions and often take at least two sets of partners to deliver. I would say most of them have more than two partners. So thinking about how partners actually work together, right? Who are the partners? Do they actually have the capabilities and resources, including people and knowledge and tools to deliver this intervention effectively? What are the other sectors that need to be involved as you think about the environment, right? The policy environment, the reimbursement environment. Who are those other players or stakeholders that need to be part of that partnership? And then as you think about all those things, then you can think about what is the program? What is the specific intervention? How do I design it and how do I implement it? Understanding all these other factors. And then the final step is trustworthy relationships. This is getting to that interpersonal component of the sociological model, that the relationships are not just between the organization delivering the intervention and the participant receiving the intervention, but the relationships are between the partners and between the suppliers and the people representing the customer and the infrastructure, the people in the political and economic environment behind you. So those trustworthy relationships go throughout all of the players in every one of these blue boxes. So we thought about it in this way, and we think there's a lot of opportunity to take a conceptual model like this and actually start to test this. And we'd be very open to anyone who wants to help us build this out and to test different components. But this is just our initial thinking on it. Okay. The next thing is that societal value. Why are we even thinking about digital health equity? What is the societal value to it? And so this is just one example of the societal value I thought of in terms of the intervention example I'm about to give you. And that is lifespan versus health span. Really, the goal of healthcare has been in increasing the lifespan, the years of life. And globally, it's just over 73 years. So we've been pretty successful through healthcare and public health interventions in increasing lifespan. But the health span is a term that's come about in the last few years that's defined as the years free from chronic illness or disability. And the global average health span is 63 and a half years. So that gap is 9.6 years on a global basis. So I did a calculation just from the United States. And what that converts to is this. So if we had one more year in health, in the health span, so instead of 63 and a half, we got it to 64 and a half. In the US, that would convert to $840 billion in economic benefit because we know chronic disease really drives a lot of healthcare spending in the US. I'm sorry, I didn't mean that I calculated it. There's a paper that actually provided this. So, and I have that in the references. The second example is dementia. Dementia is driving a lot of healthcare costs, and if we were to delay dementia by 3 years, that would provide 209 billion in benefit to the United States. So it increases the quality of life and the ability to be productive for individuals and their families, but it also has a substantial economic or societal benefit that allows us to take those savings and do other things with them. So that's an example of societal benefit, not just based on my particular project, my particular population, but how we contribute to the overall societal value. So this is where the promise of digital health and AI really comes in, because I think it is probably naive for us to think somehow we're going to get these levels of cost savings by just improving processes, right? Just taking kind of old ways of thinking about how we reduce, cutting services, improving quality, those kinds of things. It's going to be very hard to leverage enough of that because of how difficult it is to actually bend the cost curve. But I think with digital health and AI, we can bend the cost curve. And if we just focus on trillion-dollar diseases, and the top two are diabetes and cardiovascular disease, we can actually substantially bend the cost curve for the entire society. With digital health and AI, we can also enable optimal and personalized care, right? The technologies allow us to improve workflow and to tailor what we do for individuals. It can also help us reduce the time to deliver those optimal and personalized care plans. And then finally, it will give power to individuals to drive their own best health because it puts some of the control of the data and the insights back into the hands of individuals. So I'd like to give you an example. We are doing work in digital health and in AI, but I think I only have time to give you the example from digital health. So this is a real world implementation of a digital health equity intervention. The company that I founded is called Health Tequity. And this was a project that I did as a researcher actually before spinning off Health Tequity. So the research I'm sharing you was done while I was a full-time faculty member. We have now taken that technology and spun it out into Health Tequity. So this is the results of a research project. So Health Tech Care, the goal of it was to improve chronic illness with remote patient monitoring and health coaching in the Central Valley of California, which is the very vast rural area of the central part of the state that is the largest agricultural producer for the entire United States. But it also has the worst health disparities and is heavily populated by agricultural workers. So that's where we did these projects. It was co-designed with patients, family members, clinicians, and clinic staff. And we were solving technology adoption challenges of the patients and the clinic while we are developing a digital health intervention. So first, co-design. We brought together a group of co-designers that included nurses, medical assistants, providers, the patients, community health workers, navigators, and family members to a co-design team to help us develop the technology, the intervention, the communication, really all aspects of this program. In the first clinic where we did the most in-depth co-design, we actually had 25 participants. Co-design, you might hear of co-design projects where they bring people together in workshops. We did something a little bit different. I call it embedded co-design. So rather than having a workshop that is done on a, one time or two-time basis, and you bring people off-site and they are with you for 4 hours or 8 hours, we embedded ourselves as much as possible into their environment. So we actually started in the end of 2020, so it was COVID, so we could not physically be there in person. So they were doing a lot as in meetings, and then a few things in person in the clinic, masked up and things like that. So we followed along with them wherever they were, we were there. So we were in probably 10 to 15 Zoom meetings a week with them, and then occasional in-person interaction in the clinic. So we were embedded with them in the way that they were working through their own healthcare and their own telehealth visits and things like that. So what did we actually produce? Well, we're focused on diabetes and hypertension, which were the two most common chronic conditions in this population, and the ones that the clinic was most concerned about losing touch with. So they said, we need a way to stay engaged with these patients and to monitor what's happening so that we know when to intervene. So we created this platform, digital care coordination and remote monitoring, to automate workflow and generate timely data for the patients. So we use commercially available devices. We focus on glucometers and blood pressure cuffs, scales, fitness watches, and provided those to the patients based on the physician saying, okay, this is a patient who is eligible, and I would like them to get these devices. We had a mobile application that automated the Bluetooth pairing process between the device and the mobile app, and the patients could see the data in their own mobile app as well. That data was collected automatically from all the devices that were identified and then sent over to the clinic. So this is what we did for the clinic. So for the clinic, they wanted their medical assistants actually to monitor the data, not to make assessments, not to make treatment decisions, but to be able to monitor, is data coming in? How are the patients doing? Do they need anything from us? So the data came into a portal for each clinic, separate portal for each clinic, where they could see all the patients enrolled in the program. They could drill down to each individual patient, and they could identify those that needed some sort of outreach or referral, or maybe just a check-in. The medical assistants were also trained as health coaches, so not only were they looking at the data, they were actually doing the follow-ups with the patients as well. So the data came into the portal in real time, and then we integrated it with electronic health record systems so that the clinicians would see it in the EHR, because we knew they were not going to log into some other portal, some other system to see this information. So it had to get into the EHR. And then we did some simple data visualizations. Really what they wanted to know is how many patients are actually sending data in, where the patients whose measures are out of range, which are the thresholds that the clinicians set, and who do I need to follow up with? So we have very simple visualizations and sortable views in the dashboard so they could answer those kinds of questions very quickly. All right. So the other set of issues in implementing digital health interventions is that the clinic settings that serve patients who are low income or uninsured or have public insurance, really they have their own digital disparities, right? The staff have not run digital care programs before. A lot of them did not know how to use these technologies, and they didn't know how to organize all of it. So as we did these implementations, we created tools and templates that they could use to implement and to continue to improve. So they were things like assessment tools, that created patient journeys that went along with best practices guidelines. We had patient educational tools in written form as well as in videos in 4 languages. And then we helped scale up the medical assistants. Since they were the primary contact with the patients, we trained them as health coaches. So we had created through a different project an medical assistant health coach training program for them to learn about diabetes and hypertension, how to do motivational interviewing, and how to work with the patient over time. So we had already created that program, so we offered it to all the sites that were in this research project. So again, we're trying to fill the gaps in digital divide for the clinics as well as for the participants. So here are the outcomes. So we had four sites that were in these pilot studies. For diabetes, this is an aggregate of all four sites. We had 157 individuals. They started an average of 11.1 hemoglobin A1C. For the clinicians in the audience, I'm sure you will be catching your breath at that high in A1C, right? A normal A1C is 5.6 or below. Up to 5.7 to about 6.4 is prediabetes, 6.5 and above is diabetes. 11.1 is extremely high. And that was the average A1C at the start. Within 6 months, they had reduced to an average of 7.5. So for people who've had diabetes for a long time and have been at that high in A1C to start with, getting it down to 3.7 points down is a really dramatic effect. Similarly, for blood pressure, we had 116 individuals with hypertension that started at over 150 systolic blood pressure and over 84 diastolic, and they reduced their systolic blood pressure by 20 points and diastolic by 3.5 points. On both of these charts, you're seeing our results from this project in the green. So it's a reduction in A1C or a reduction in systolic and diastolic blood pressure. And then the gray and the blue bars are the published literature. You can see that our results are dramatically better than what's in the published literature. And I truly believe that the reason for that was that co-design process. We were working through how this should work, what the tools should be, what the barriers might be, why things would not work. We are working through all those things in real time as we designed with our teams. So that every time we came up with a problem that they said, oh, we can't do this because of that. We said, how do we solve that? Right? Not waiting until the very end to find out all the problems that we hadn't anticipated. Was every time we had a problem that we were anticipating, we would solve it as we went. So I think this is really one of the reasons why we got such good outcomes, because it really fit with the environment of these clinics. Remember, it's 4 different clinics. So it's not that we said every clinic has to do the same thing. We went clinic by clinic and said, how can we make it work best for your clinic? Okay. So what does that do to societal value? So we took these outcomes and we looked at the published literature that has estimated, at least in the United States, what those kind of outcomes would translate to in health system savings. And our A1C results would have reduced the cost for the health system by $326 per person per month. For the systolic blood pressure improvements, it would save the health system $191 per person per month. These are really substantial savings. We didn't estimate the health span increases in this population, right? But we were able, because I think we need a much larger sample size to be able to say population level generalizability. But here we could actually see the kind of cost savings we could get in these 4 counties where we did the pilots. We could actually see and estimate what those cost savings might be there. So these are really, we think, very positive potential societal value. So we really believe that the next opportunity here is we've got great pilot outcomes. We have an understanding of the frameworks that are used to design digital health equity interventions and what the concepts are and how we might measure those things. Now we need to really put it all together. If we have positive examples, how do we scale those from a pilot outcomes to a population level impact, right? How do we go from these 4 individual health centers in 4 counties in rural California now to all the Central Valley, and then to rural communities across the country? In order to do that, we are not naive enough to think, well, it worked here, so we just take the whole thing and plop it over there, and it's going to have the same outcomes. You really need to sort of stay true to the co-design principles and to understand the differences. Maybe everything doesn't need to change, but what are the things that do need to change to make sure it fits into that environment? And by working together to develop a framework for digital health equity interventions that allows us to do that translation in a really rigorous and well thought out way, but efficiently, so it doesn't take us 3 years to do every one of these projects as research studies, to do it efficiently, then we can get to the point where our digital health equity interventions are empowering the individuals and the local healthcare providers to optimize health span for themselves and then broadly for society. And that I think is really the most exciting opportunity that I see going forward for us. So that's just a big picture of that framework that I'd love to collaborate with people on working towards that. And then there's the references if you're interested in them. And with that, I will conclude my presentation and say thank you so much for this opportunity. And I would welcome any follow-up from people who might be interested.